So welcome. In today's session, you're going to look at the hip joint. And by the end of this session, you should know which type of joint is the hip joint, what are the articulating surfaces of the hip joint. You should know the capsule and the ligaments around the hip joint. You should also know the stability factors, both the static stability factors and the dynamic stability factors. You should also know the neurovascular supply of the hip joint. And you should know the relations of the hip joint. And finally, you should know the movements of the hip joint and the muscles responsible for each and every movement of the hip joint. Welcome all. My name is Wallace Munyeri, and I'm the Yule Daktari. So, hip joint. Let me hide this a minute. Okay. So, hip joint. What type of joint is it? It is a multi-axial synovial joint of ball and socket variety. Okay. So, it is a multi-axial synovial joint of ball and socket variety formed between the acetabulum of the innominate bone and the head of femur. So, those are the articulating surfaces. It is the largest ball and socket type of joint in the body. I've said it is the largest ball and socket type of joint in the body, but it is not the largest joint in the body. The largest joint in the body is the knee joint. Okay. The main functions of the hip joint are one, to support the body weight during standing, and also to transmit the forces generated by movements of to transmit the forces generated by the trunk, by the femur to the trunk during walking. So they have indicated that I've not indicated that correctly there, but to transmit the forces from the femur to the trunk during walking. So which are the articulating surfaces? Now, as I have said in a few minutes ago, the head of femur articulates with the horseshoe-shaped acetabulum of the hip bone, forming the hip joint. Now, the head, let me take a lesser pointer. Now, the head of the femur forms more than half of a sphere, okay? And it is covered by articular hyaline, except at the tip of the head, where a small pit is excavated there. That pit is known as the fovea capitis, okay? And there is where is the attachment of ligamentum teres femoris, okay? So now the acetabulum, it presents three surfaces: a horseshoe-shaped lunate surface, okay? It has a lunate surface, it has an acetabular notch, and acetabular fossa. Now, out of this, only the lunate surface is the articular part, okay? And it is covered by articular cartilage. The acetabular fossa, within the acetabular fossa, we have a pad of fat known as the Hervesian pad of fat, okay? And now, we have a ligament which traverses the acetabular notch known as the transverse acetabular ligament. Now, the depth of the acetabulum is increased by the acetabular labrum, okay? Now here we have, this is the head of femur, forming more than half of a sphere, okay? Okay, then you can see here at the tip, we have this is the fovea is here, and attached to the fovea is the ligament teres femoris, okay? Then you can see within and this ligament is the same as this, it has been cut. Then you can see here a horseshoe-shaped surface, the lunate surface. Then here is the acetabular fossa. It is filled with the Hervesian pad of fat in the living. Then you have here the acetabular notch, but here we have the ligament which bridges the acetabular notch to convert it to a foramen, okay? So then around here, you can see this is the transverse acetabular ligament here. Then around the attached to the acetabular rim is the acetabular ribrum, which increases the depth of the acetabulum. Okay. Now, hip joint capsule. Now, the capsule of the joint is attached circumferentially, okay, around the acetabular ribrum and the transverse ligament. Then it passes laterally like a sleeve to be attached to the neck of femur. Now, anteriorly, it is attached to the intertrochanteric line, but posteriorly, it extends half the distance of the neck of femur, okay? It is attached halfway along the femoral neck. The other half is occupied by the tendon of obturator externus muscle. The capsule is loose, but extremely strong. Now, from the attachment, from the femoral attachment, fibers, the outer fibers of the capsule are reflected back along the neck of femur to the acetabular margin of the femoral head. Okay. Now, these reflected fibers constitute the retinacular fibers, and these retinacular fibers, they bind down the nutrient arteries that pass chiefly from the trochanteric anastomosis along the neck of femur to supply the major part of the head of femur. Okay, now let me do that easily. The outer longitudinal fibers of the capsule, once they are attached to the femur, they are reflected back. Okay, they are reflected back along the femoral neck towards to reach the articular margin of the femoral head. Now, as they are reflected, they will bind down retinacular arteries, chiefly from the trochanteric anastomosis. And these arteries, the retinacular arteries, they supply major part of the head of femur. Now, that is why the fracture of the femoral neck, when you have a cervical fracture, okay, of the femoral neck, that is within the capsular attachment, and there will be the rupture of the retinacular fibers and the retinacular arteries and veins. This will cause a vascular necrosis of the head of femur. So once you rupture those arteries, there will be no supply of blood to the head of femur, and this will cause cell murder. The osteocytes, the cells forming the head of femur, that is bone, they will die. So they will be, it is like you are killing them intentionally. Cell murder. Cell murder is what I call necrosis, but cell death is apoptosis. Cell murder, you are doing it intentionally. So that is necrosis. Now, the capsule is made up of two layers, inner circular fibers or the zona orbicularis and the outer longitudinal fibers. Okay. I've said zona orbicularis, the inner circular fibers. Now, these fibers, the zona orbicularis are not directly attached to the bones, but the outer longitudinal fibers are reflected along the neck toward the articular margin of the head of femur to form the retinacular fibers that I have said. Here we are. This is where the capsule is attached around the acetabula, circumferentially here. Then anteriorly it is attached along the intertrochanteric line, but posteriorly it is attached halfway along the femoral neck. The other half here is occupied by the tendon of obturator externus muscle. Okay. Then, as you can see, once attached, some fibers are reflected along the femoral neck, and as they are reflected towards the articular margin of the head of femur, they will bind down these retinacular arteries or the subsynovial arteries. These arteries mainly originate from the trochanteric anastomosis and majorly from the medial circumflex femoral artery. Okay. We will look at that. Now, ligaments of the hip joint. Now, the fibrous capsule is strengthened by three ligaments which arise from each of the constituent bone of the innominate bone. The iliofemoral will arise from the ilium, pubofemoral from the pubis, ischiofemoral from the ischium. Now, let's start with the iliofemoral ligament or the iliofemoral ligament of Bigelow. or the wire ligament of Bigelow, whatever you might call it. It is the strongest of the three and has a triangular shape. Now, the apex of this triangle is attached to the lower half of the anterior inferior iliac spine. Remember the upper half of the anterior inferior iliac spine is that is where the straight head of rectus femoris originates from, but the lower half, that is where the apex of the wire ligament of Bigelow originates from. Now, the base is attached to the intertrochanteric line. Now, the margins are usually weak, and the ligament has an appearance of an inverted V, and that is why it is called the Y-shaped ligament. It usually prevents hyperextension at the hip joint, hyperextension. Now, pubofemoral. It is attached to the superior ramus and the obturator crest of pubic bone. It passes distally deep to iliofemoral ligament and blends with the capsule. It lies inframedially and supports the joint on this aspect and prevents over abduction of the hip joint. Okay, ischio-femoral. It is the weakest of the three. Arises from the posterior inferior margin of the acetabulum, and its fibers passing laterally to the capsule. They usually spiral upwards and blend with the zona orbicularis of the capsule. Okay, let me show you that in the diagram. Here you can see this is the anterior superior iliac spine. This is the anterior inferior iliac spine. Now from the lower half, that is where the apex of iliofemoral ligament originates from. From the superior half, straight head of rectus femoris. Then you can see it has this, it is attached to this intertrochanteric line. You can see it is somehow Y-shaped or V-shaped. It's like an inverted V. So it has two bands, a horizontal band here and a vertical band. Then this is your pubofemoral ligament. Usually prevent over abduction. This prevents hyperextension. Okay, this is the head. Let's look at the posterior. Then you can see here ischio-femoral. You can see it is somewhat spiraling, and as it spirals, it blends with these fibers, the zona orbicularis. Now, stability factors. When discussing stability factors, you state the static stability factors and the dynamic stability factors. Now, the stability of the hip joint is provided by the following factors which prevent its dislocation. Now, when discussing about stability, please note this. The stability of a joint and the range of movement of the same joint are inversely proportional. So, the more mobile a joint is, the less stable it is. Okay? And the more stable a joint is, the less mobile it is, if I can use that. So if a joint has the higher the stability, the lower the range of movement of that joint. But hip joint has both. It has a high stability, and also the range of movement is also good. It also has a high degree of range of movement. Why? Because one, the depth of the acetabulum and the narrowing of its mouth by the acetabular labrum enables there to be a snug fit of the femoral head into the acetabulum. Okay, so and the acetabulum is deepened by the acetabular labrum, and this makes the hip joint very stable. Okay, and this is a static factor. Now, also, there are very strong ligaments, iliofemoral, pubofemoral, and ischio-femoral, which strengthen the capsule of the joint. That is also a static factor. Then, one dynamic factor is that we have the surrounding muscles, the short muscles of the gluteal region. They are strong, and they will originate from the constituent bones of the innominate bone to insert into the femur. So they are somewhat bringing the two bones together. So they contribute to stability, but they are dynamic stability factors. Okay. Then the joint is least stable when the hip joint is flexed and adducted. Dislocation of the hip joint requires a considerable force. it is very rare you hear someone has dislocated the hip joint. Okay, but it may occur in serious accidents where the head of femur is typically dislocated posteriorly, and often there is an associated fracture at the back of the acetabulum. Once the head of femur is displaced posteriorly, it might injure the sciatic nerve, because sciatic nerve lies posterior to the hip joint. That is why it is a must for you to know the relations of the hip joint. Now let's look at the neurovascular supply. Now, blood supply. The capsule and the synovial membrane are supplied by the nearby vessels. The head and intracapsular part of the neck receive blood from the trochanteric anastomosis, mainly through branches of medial circumflex femoral artery. Okay, and these arteries pass as the subsynovial stroke retinacular arteries, namely the anterior, posterior, and superior. Okay, although the artery in the ligament of the head of femur, we also have an artery in the ligamentum teres femoris, or the other name of ligamentum teres femoris is the ligament of the head of femur. Within it, there is an artery which originates from the obturator artery, and that artery is important in young children, but it usually atrophies at the age of 7 years. But in some cases, during it can bleed in adults, suggesting that it might remain patent. Okay, nerve supply is supplied by the hip joint is supplied by the femoral nerve via the nerve to rectus femoris, also by the obturator nerve directly from its anterior division, also by the nerve to quadratus femoris, also by articular twigs from sciatic nerve. Okay, then the femoral nerve, okay, obturator and sciatic nerves also supply the knee joint. That is why pain in the hip joint might be referred to the knee. Okay, so here is the blood supply. You can see this is ligamentum teres femoris, and you can see within it we have an artery. This is a very important source of blood supply to the head of femur, especially in children. Then here you can see the retinacular arteries originating from the trochanteric anastomosis and mainly from the medial circumflex femoral artery. Okay. Also, we have the nutrient artery. We will also supply part of the head, only a small portion. The most important ones are the retinacular arteries. That is why when you have a cervical fracture here of the neck of femur, there will be a vascular necrosis of the head. Now, relations. Now, anterior to the hip joint, we have the femoral triangle is located anterior to the hip joint. That is, we have the tendon of iliopsoas separated from by the joint by the synovial bursa. Okay, then we also have a pectineus muscle, the straight head of rectus femoris. Then we have femoral nerve. You can see these are contents in the femoral triangle: femoral nerve, femoral artery, and femoral vein. Remember, the vein lies medial, the most medial, then the artery, then the nerve. Then posteriorly, we will have the structures located in the gluteal region, that is these muscles. Okay, you also have the nerves. You can see all these are the structures located in the gluteal region. Then superiorly, we will have the deflected head of rectus femoris, lying medially. And remember, the deflected head of rectus femoris originates from a groove which is above the acetabulum, the supraacetabular groove. We also have gluteus minimus, medius, and maximus laterally. Okay, as they go to insert into the greater trochanter. Then inferiorly, we have the pectineus and the tendon of obturator externus. Laterally, the capsule of the hip joint usually bend with the iliotibial band, and medially, the floor of the acetabular fossa forms part of the lateral wall of the pelvis, and in females, the ovary lies adjacent, separated only by the obturator internus obturate a nerve and vessels in the peritoneum. So you can see how if you have if the femoral head is displaced medially, in females it can even injure the ovary if it fractures the medial wall. Okay, so here we are. These are the superior relations. Okay, anterior relations. You can see this is the contents in the femoral triangle. Then inferior relations, posterior relations. You can see this is the gluteal region here. Okay, you can see the external rotators. Okay, and the sciatic nerve. That is why when I have said when there is a posterior dislocation, it might injure the sciatic nerve. Now movements. All this, it is a multi-axial joint, so it has these movements. Flexion, produced by these muscles, okay, psoas major and iliacus being the chief flexors. Extension, the hamstrings and the gluteus maximus. Abduction by the gluteus medius and minimus. Please remember this, especially in the Trendelenburg's sign. Okay, then you have the tensor fasciolata and sartorius. Adduction by the adductors, okay, the muscles of the medial compartment of the thigh. Medial rotation, we have the anterior fibers of gluteus minimus and medius and the tensor fasciolata. Lateral rotation, we have the 6 lateral rotators of the hip joint. 1, 2, 3, 4, 5, 2 gemelli and quadratus femoris, 6 of them. Please remember this. And these are the movements: extension, flexion, okay. Abduction is taken away from the midline, adduction towards the midline. Also, this is abduction when you are lifting the leg. Okay, remember this, especially in the Trendelenburg's sign. This is internal rotation or the medial rotation, lateral rotation, then circumduction. You combine these movements, you extension, flexion, abduction, adduction, you get circumduction. So we have come to the end of that session. Thank you for your attention, and please subscribe for more anatomy and biochemistry content. Thank you.